All right, so why do we even pull together a consensus? Why did we even think that this was necessary? Well, we have lack of guidelines. If you do a lit search on guidelines for intermittent catheterization, there are absolutely zero in America, and you'll see my lit search results, and there's very few anyplace else. There's lack of standardization. How I teach ISC is very different than how Glenn teaches it, how Gina teaches it, because you know what? We were all taught differently. So there is not a standardized area. So we really need to look at this. It's the same thing, so why aren't we all teaching it the same way? We really should be teaching it the same way. There's lack of evidence-based practice. We all talk about evidence-based practice. When I was a first nurse, I didn't even know what that was. We never talked about that. But we talk about evidence-based practice now, and you know what? Nursing is the one that really looked at evidence-based practice and brought it into the field. So we should start looking at that. Does that mean that every one of you needs to go out and do a study? No, but maybe if you're looking at something that's a little different in your education and you think it helps, come talk to me or Suzanne. We'll help you figure out how to do a pilot study and publish it and start getting the evidence out there. It's really that easy. Urology is so far behind the times from any other subspecialty in evidence-based practice, it's kind of sad. It really is. Cardiology has the evidence. Neurology has the evidence. Urology lacks the evidence. So we really need to start looking at that. Lack of assessment requirements. What kind of assessments are we doing on these patients? We all know what we think we need, but has anyone really looked at that as a group? How do we figure out what assessment pieces you need? Avoiding that lower urinary tract trauma. Any of you that watched Dr. Kennelly's lecture, he really made a big point of how the lower urinary tract trauma is happening, and we're probably not even realizing it. As I was watching the new catheter by Coloplast, one of the things that I wondered was when I saw that the bladder actually fell into those two islets, what kind of trauma is that causing? And we're doing that 6 times a day. I never thought of that before. I've always repositioned, so that wasn't the emptying wasn't the big piece for me because I've always repositioned. That was what I was taught. But I was shocked to see that when they asked, most people weren't repositioning. So, there's pieces out there that we all do and have, so maybe we can come to consensus and try to figure out how to make it easier and better to avoid that lower urinary tract. We want to prevent complications. UTIs is huge in this patient population. You saw the statistics by Dr. Kennelly. I'm not going to go over them again. Hematuria, we all know that. We get the phone calls, right? I've been cathing and I've got hematuria. I've been cathing and, I've got burning now every time I place a catheter. Those are signs and symptoms of concerns for UTI, so we need to start pay attention. So we got together as a group and because really there's nothing out there to support any of this. So we identified the need that we needed a consensus-based best practice statement. Why did we have to go with consensus-based? Because I've already explained to you, the evidence isn't out there. So we pulled together a bunch of experts, which I was included. I'm not sure I'm an expert, but I got invited, so it was nice. Consensus-based practice statements. So we really got together a group of, I think it was 10 or 11 people, and instruction for self-assisted intermittent catheterizations and guidance for catheter selection was the 2 goals we had when we pulled this group together. We started with the steering committee. The steering committee really kind of set the goals and worked with Coloplast very closely to make sure that we were doing what we thought was best. So we started with the steering committee, which was Dr. Enberg, Dr. Gray, myself, and Dr. Kwalik. And then we added the consensus panel. We had Tamara Dickinson, Leah Holderman, who was an occupational therapist. We had Danielle Hausman, who was an occupational therapist. Had no idea prior to this consensus how much work occupational therapists were doing in the rehab settings with these spinal cord injury patients and actually teaching intermittent self-catheterization. I didn't realize that. This was a huge eye-opener for me. And I've been teaching ISC for 22, 23 years, had no idea I could refer to an occupational therapist and how important that is. So the fact that Coloplast brought those in to us with the rest of the nurses was huge for us because it really made a big difference. We had Jennifer Lewis, Dr. Lewis, who is a nurse practitioner. We had Dr. Newman, who is a nurse practitioner. And we had Tom Thompson, who was out of the VA and had that VA piece, which some of us sometimes don't realize how important that is because they have a lot of people cathing due to the injuries and ages. So we had a pretty good consensus panel. They were all invited and known experts in their field, and so it was a really good group of people. You would think that getting a group of people like this together, we could never come to consensus because, oh boy, but you'll see that we did, and we did some really good work. So we did a scoping review. The difference between a scoping review and a, look at that, my cardiac brain just dropped the other review. There's two different types of review out there. But the scoping review is a little less rigorous. Yeah, it's a little less rigorous, and mainly that's because there's not evidence out there. So that's why we did a scoping review, because we knew we weren't going to find the evidence. So our inclusion criteria were quite a bit, right? We looked at any quantitative or qualitative research studies conducted in the United States. Oh, systematic review is the other one. There it is, right there in front of me. So the systematic, we did include any systematic reviews that had a meta-analysis at one patient. So a systematic review by itself just kind of reviews the literature and tells you what to find. A systematic review with meta-analysis pulls all those reviews together and tells you what the overall review is. So we looked only at the systematic reviews. We looked at healthcare system or professional organization and evidence-based clinical practice guidelines. Really not as easy to find. Some people publish them, some don't. We looked at adults only. If it was a research study examined an educational intervention for ISC or reported findings related to outcomes. And if it was a clinical practice guideline, it had to show how the evidence supported their guideline. It couldn't just be someone's opinion. Exclusion criteria were things like editorials, letters to the editors, case studies, because one case study and what happens isn't enough to conclude as evidence. It can begin to build the evidence, and a series of case reports on the same thing can build the evidence, but one case study alone does not. So we excluded those. Clinical practice recommendations. If it wasn't published in English, we didn't do it, and that's good because I can't read foreign languages. And I had to read all these articles, so yeah. Anything that was conducted in an acute or long-term care setting, we really debated this at first because we weren't sure how we wanted to handle that, but we cut out the acute care setting because the rules are so different from what we're teaching. And this was about teaching ISC, so we cut out the acute care because, and we'll talk about that in a minute, because you'll see the rules are different. We cut out sterile technique for the same reason, and we'll talk about that in a minute. Okay, so we looked at articles published between 1/1/2005 and 9/30/2021. We looked at PubMed, Embase, and CINAHL. We used a reference librarian who used a combination of medical subject headings, mesh terms, and free terms provided by the authors. And, we had intermittent self-cath, we had just about anything you can imagine. One of the important things when you're doing a really good scoping review or a systematic review is really, if you can, get a librarian involved, because that's their role in it, is to find these articles for you and to help you with your mesh headings. So it was really important. I was out of, don't quote me, I think it was University of Minnesota, I think is where she was from. Is that correct? Yep. Oh, good. See? I'm not as old as I thought. All right. The flow chart shows here that initially we started looking at 5,034 articles. That sounds like a lot, but when you think about how much ISC is going on, it really isn't that many, right? Look at all of our criteria, and we only identified 5,000, even just without even looking at them. But if you look down, we ended up with 11 that we included. So that's why the evidence isn't there. It's just not there. So the scoping review, this is what we found. One pilot study examined the effectiveness of an educational intervention. Only one study looked at whether or not how we were teaching people actually worked.